Good morning, everyone. Today I'm going to speak about a brief overview of dystonias. 2 weeks ago, in the rotation, I have seen a patient with a dystonia, which has a cervical dystonia, who was moving her head like this, which made me wonder what it is, why it is happening, and I wanted to learn more about it as well as to share it with others as well. And here we go. So, what is dystonia? Dystonia is just a definition is actually a sustained or intermittent muscle contraction, which means that when the muscles is contracting. For example, you're trying to flex this muscle. What happens is one side actually contracts, whereas other side relaxes. In some cases, what happens is that both sides will be contracting at the same time, and this causes this muscle to this hand arm in this case to just stay stationary. At the same time, it causes intense contraction, which causes pain. So that is dystonia. That is dystonia. And next is this is the third most common movement disorders. The first and second being essential tremors and Parkinson's disease. It is actually seen in 16.4 cases for every 100,000 population. And among them, the most common is actually cervical dystonia. Weirdly enough, it was considered to be actually a psychogenic disorder. It's because that whenever the dystonia occurs, and what patients actually do is they try to keep their hands over here, which actually resolves that issue. So when doctors try their best to understand why it is happening, and then they were thinking that this may not actually be a neurological disorder. This is actually maybe a psychiatric things. I personally thought that if neurologists don't understand, they blame it on psychiatry, but I don't know. And I will tell you why they were considering it is a psychiatric disorders in following slides. And before we go for that, I need to talk about a little bit about special features of dystonia. First of all, it is action or task specificity. For example, in case of authors, what happens is they get something called as writer's cramp. So what is writer's cramp is like when their hands just fixated on this and which does not allow them to write. This is because of prolonged writing, so which causes their hands to be like this. For at the same time, there's also one more condition which is called as musician's cramp. So this is the same. For example, a violinist will be developing cramps over their hands. So from this, they understood that it is maybe an action or task specific. Next is overflow phenomenon. So what is overflow phenomenon is that, for example, if I'm developing a cervical dystonia, so my neck will be like this. So sometimes what happens is the dystonia starts spreading. It starts spreading to the hands. It will be like this, or it will be spreading to my abdomen, to my back muscles as well. So that is called as overflow phenomenon. So it's not staying in one muscle, one area, but it is starts spreading. Next is diurnal variation. Diurnal variation means that the patients will be all right in the morning, but when the day progresses, their dystonia starts occurring. I think this is more common. This is also seen in other disorders, such as, for example, in myasthenia, or in case of when the patient is having delirium. So when the day progresses, their symptoms actually gets worse. Same as in this case also, they have the same symptoms as well. Then this is the thing that made people believe that this might be a psychiatric disorder, which is sensory trick, also called as geste antagoniste. So what this means is that whenever the patient is having cervical dystonia or or any other dystonias, there are few specific points in that dystonic areas, and when you touch that point, the dystonia just goes off. For example, if I just keep my leg like my neck like this in a dystonic position, and if someone just touch over here or anywhere in this point, this is also called as null point. And when someone places their hand or touches that area, my dystonia just goes off. And we don't know why it is happening. There are some theories to it. For example, there might be sensation, and this sensory nerves is going to the brain and just telling the basal nuclei and other parts of the areas to just and access as an inhibition. So this is also one of the treatment method that we are doing as well. And as I said, there may be a diurnal variations. At the same time, there might be a exacerbating factors as well as relieving factors. So first we go for exacerbating factors. Whenever they have stress or whenever they have anxiety, their dystonia just pops up. And if they're already having dystonia, it just becomes worse. Their pain just gets worse. Whereas if they relax or if they go to sleep, then they become then those dystonic symptoms just comes down. So these are some of the features. And on the next slide, this is one of the sensory phenomenon I was talking about. On the left hand side, this woman is actually having a cervical dystonia. You can see that her neck is actually downwards and on little bit on the lateral side as well. Whereas once she kept her hand over her chin as well as on the back, her dystonia just goes away. So this is why the doctors in the past were thinking that this might be a psychogenic disorder. And there are also neurological causes of dystonia. There are also psychiatric causes of dystonia as well that I will speak about it later. On the next slide, I will just go a brief about classifications. There are a lot to speak about it, but I will just speak only the very important ones. First, based on age. So there can be an early onset, which can be seen in pediatric populations, and also in late onset, which can be seen only on adult populations. In pediatric population, the problem is it will be generalized. Generalized means that first it will start with legs. So legs will be dystonic, they will be unable to move, and it will be very painful. And slowly, unfortunately, it starts progressing to the other parts of the body as well. And that's one of the features when the dystonia starts showing up in the pediatric populations. Whereas in late onset, it will just be on one side, one part of the body, for example, in hands or example in eyes. And it just stays there only on other. If there's another like genetic mutations or something like that, then you can see other progressing to other body parts. Next is drug induced. Drug induced is also called as tardive dystonia. So what happens is that this is a hypothesis which says that dopamine plays a part in this. When you block dopamine, the muscle contraction gets haywire. And because of that, they develop dystonia. This is more commonly seen in patients who are on antipsychotics, which has a dopamine blocking activity, and also antiemetics. Whoever is vomiting a lot, they will be prescribed, if they were prescribed metoclopramide, which also has a dopamine blocking activity. And if that is prescribed and it is being taken for a long time, then our brain starts developing new neurons which starts causing dystonia. So this is called as tardive dystonia, and it can be relieved once you stop taking those drugs and replace with another drugs. And there's one more thing which is called as isolated and combined. Isolated is only when you have dystonia. Combined is when you have dystonia and you also have other neurological problems as well. For example, if the patient is having dystonia, the patient is having tremors, the patient is walking very slowly. These are all features of Parkinsonism. And in top of that, they also have dystonia. Then that is called as combined dystonia. And this is also seen in cases of, for example, Huntington's, or it can be seen in Wilson's disease also. So in that case, they have dystonias. At the same time, they have other neurological features as well. So that is called as combined dystonias, and one of the examples would be Wilson's. And I have also mentioned rapid onset dystonia, Parkinsonisms, and also dopa responsive dystonia. So dopa responsive dystonia is very special actually. So what happens is that these dystonias will respond only to dopamine. Okay, yeah, there are other medications that can be given for dystonias, but it will be very refractive, whereas only dopamine works on this subtype of dystonias. And the other main classification is based on where it is, where the dystonia is. For example, focal is only on one organ, one part of the area. For example, blepharospasm. In this, the patients just they just tightly close their eyes, like the muscles tightly close their eyes. So this is blepharospasm. I have seen a patient who had a traumatic brain injury, and after that, he wasn't able to open the eyes properly. It's called as blepharospasm. And also other causes, other types such as oromandibular dystonia, laryngeal dystonia. In laryngeal dystonias, they have speech disturbances, and that is a very big issue. And also next we'll go to segmental. Segmental is when they have two other contiguous body regions. It means that, for example, if I have a cervical dystonia and it just nearby even my arms will start developing dystonic, that is called a segmental. And generalized is, as I told earlier, in pediatric cases, is just when the whole body, especially the trunks, is being dystonic. And multifocal is just when they have, for example, one is on the neck and one is on the leg, then that is called as multifocal. And hemidystonia is that all the dystonia is happening only on one side only. So these are dystonias. And why it is more important is like based on this, we can there are treatments can be changed. For example, if there's only one side, if only cervical dystonia is there, if only blepharospasm is there, then we can treat it with one type of medication, which is called as Botox. Or if they have generalized, then we have to think about other medications such as baclofen. So that's why this classification is more important. So these are some of the examples that I was talking about. And please focus on segment D and E. So in D, the patient is actually having a cervical dystonia, right? Whereas on E, it becomes normalized because when he starts wearing the scarf, he just becomes normalized. So is one of the things that the sensory system also plays the role. And there are different etiologies for it. For example, it can be due to a stroke. In children, it can be due to a condition which is called as cerebral palsy. It can be due to any autoimmune when our own body starts attacking our brains in case of encephalitis. And also in pediatric cases, it can be a biochemical disorders also when there are toxic products which is present in our body and it is very difficult to excrete it. So that might be causing dystonias. And understanding etiology, for example, in case of biochemical disorders, we can understand what the cause is. And if we know what the cause is, we can just treat the cause so that the dystonia comes down. So that's why we have to understand what the etiology of the condition is. So differential diagnosis. So when we see dystonia, first we have to identify what dystonia is. And after that, we have to know whether the patient is actually having a dystonia or not. For example, in case of functional dystonia, it looks like a dystonia, but you won't have other features of dystonia at all. And also there might be a past history of any psychiatric disorders or any mood disorders will be present. So we have to find that, we have to identify that and treat it accordingly. Scoliosis. So scoliosis is when the patient is having lateral bending of the neck, bending of the back region. So that we have to identify because that is a different department itself. And congenital torticollis, apraxia of eyelid opening, which is just the patient doesn't have that willpower to open the eyes. And also nerve palsy. For example, the patient is trying to tilt the head like this. This might be because of dystonia, or it can be due to actually the patient is having a nerve palsy. For example, a trochlear nerve palsy or not. So that also we have to differentiate it. So the goal of the treatment is actually we have to treat the patient. The dystonic patients will be having it has a very painful, and also they have their very abnormal movements like this. So we have to treat that. And since the sensory phenomenon works very well, so we have to find where that point is and try to utilize that. And at the same time, there can be a physical therapy can be used, occupation therapy and speech therapy as well. So these can be used. So it is not just a neurological problem. It's an interdepartment we have to join together and we have to treat. And what are the medications? So medications we can use like there are different medications like valbenazine we can use, baclofen, anticholinergics. There are also like algorithm also. For example, where is the dystonia present? If the dystonia is only on one side, then we can prescribe Botox. So after that, if the Botox is working, then just continue Botox. That's fine. If the Botox is not working, or if the patient is having more than one region which has a dystonia, then we can start with clonazepam. Clonazepam will act to depress that muscle contractions from the brain and spinal cord, so that can be helped. If that is not working, then we can go for the big guns. The big guns can be baclofen, it can be valbenazine, and we can go for it. If unfortunately all these is not working, then we can go for something surgical management, such as deep brain stimulation also. And there are new technologies as well, such as transcranial magnetic stimulation. So in transcranial magnetic stimulation, you just put a magnetic stimulation, a magnetic field, so that it depresses the muscle contraction, or transcranial electrical stimulation, where you use electricity to depress the muscle contraction. So this is what I was talking about, surgical management. In that, one is intrathecal baclofen. Intrathecal means you're just injecting to the spinal cord itself, the baclofen, and baclofen will help to reduce the contraction. And ablative lesioning, what does ablative lesion means? So what happens in the brain, we just specify and understand where that area, which area of the brain which causes the contraction. So in that, we just destroy very minutely, so that this contraction actually reduces. Most commonly, it happens in thalamus, thalamotomy they say, and you can ablate that area. Next is DBS, which is deep brain stimulation. On the photo here, I have showed that you just put a stimulator over there, and it just tries to depress the contraction. So there's one more condition which is called as dystonic storm. So what happens is that dystonic storm is that when the patient is having dystonia which lasts for more hours and also leads to days. So that is called as dystonic storm. And for that, the one of the most problematic is that this dystonia will actually causes acute renal failure. Why in this case is that because the contraction is so powerful, the muscle starts destroying, and it can cause a renal failure as well. So you have to rescue the patient by giving those drugs that I have mentioned before, and also ICU monitoring should be done. So yeah, these are the newer therapies, transcranial magnetic and transcranial electrical stimulation. And there are also support groups as well, so that so that they don't feel alone. And they can also talk with other people who are going through the same issues, and and they can also learn how they are managing their life as well. So I think that while we are taking care of those patients, we should also talk about the support groups as well. And also we have to check how they are managing their life as well. Because dystonia is not only this neurological complications, this might affect their psychiatric condition as well. Because it might cause any mood disorder, it might cause depression. So we have to be there for them as well. So this is the end of my topic, and these are my references. I hope that you understood and liked the presentation. Thank you.